In this video, we describe the management of cataract in a buphthalmic eye with special focus on intraocular lens implantation in such eyes. The producers have no financial interest in the subject matter of this film. In a normal eye, aqueous produced from the ciliary body is drained mainly through the anterior chamber angle. However, in cases with primary congenital glaucoma, trabecular dysgenesis leads to blockage of this outflow pathway, causing an increase in intraocular pressure. In a pediatric eye, increased pressure on the coats of the eyeball tends to increase the size of the eye, leading to development of buphthalmos. The anterior segment of the eye especially undergoes an enormous increase in size, leading to formation of Habs striae, limbal stretching and corneal opacification over the course of time. The initial management in such eyes is concentrated on the control of intraocular pressure, the solution for which is primarily surgical. Most of these eyes do well with just the control of intraocular pressures. However, the story does not always have a happy ending. A sizable number of these eyes end up undergoing multiple surgical procedures for the control of intraocular pressure and corneal opacification, which leads to development of cataract in these eyes. Handling cataract in a buphthalmic eye offers many inherent challenges. Besides the difficulties of operating in a very large eye, intraocular lens placement offers a unique challenge. The capsular bag stretches along with the eye, leading to a relatively large capsular bag, which can be seen in vivo with the help of ultrasound biomicroscopy. In the bag, implantation of a regular sized IOL leads to decentration in almost all the cases. Sulcus placement of a 3-piece IOL with optic capture in the rexus margin has been previously described by us to achieve stability. However, an in-the-bag implantation is always considered ideal. This led us to think if a bigger, customized IOL could provide a better solution to this problem. A 3-year-old child presented to us with bilateral buphthalmos and stable intraocular pressures. The right eye had undergone a trabeculotomy with trabeculectomy and enjoyed a 20/30 visual acuity. The left eye had a complicated cataract with visual acuity of hand motions close to face. This eye had undergone multiple glaucoma procedures, including trabeculotomy, trabeculectomy and an Ahmed glaucoma valve implantation. An examination under anesthesia was undertaken for detailed evaluation of both eyes before planning the surgery. White-to-white measurements were taken to plan the appropriate size of the IOL. The intraocular lens design was conceptualized and brought to life from the drawing table to the operating room. The left eye was taken up for surgery under general anesthesia and full aseptic precautions. Limbal incisions were carefully placed, accounting for the stretched out limbus. Synecholysis was done to break the iridocapsular adhesions and free the pupillary margin. Malyugin ring was used to maintain adequate pupillary dilatation during the surgery. The interior capsule was stained with tryptophan blue dye under viscoelastic to improve visualization. A continuous curvilinear capsulorhexis was started with a needle cystitome and completed with a Utratas forceps. Capsulorhexis can be particularly difficult in such cases due to the fibrotic nature of the anterior capsule. The soft cataractous cortical material was then removed with the help of irrigation and aspiration, and the capsular bag was formed with cohesive viscoelastic. A specially designed hydrophobic acrylic giant intraocular lens was then prepared for implantation into the eye. As per the preoperative measurements, the IOL had a maximum length of 17.5 mm and an optic diameter of 7 mm, with eyelets for transcleral fixation in case of loss of capsular bag. The IOL was then loaded into an injector and injected in the capsular bag. The trailing haptic was slided into the bag to achieve stable central placement of the IOL. An adequate size posterior capsulotomy was done via the pars plana approach using a vitractor. A well-placed IOL with anterior and posterior capsulotomies can be seen here. Viscoelastic was removed from the anterior chamber and the ports were sutured to conclude the surgery. Over 1 year of follow-up, the child achieved a visual acuity of 20/60 in the left eye with a clear visual axis and stable intraocular pressures, and is currently undergoing amblyopia therapy. To conclude, intraocular lens placement in a buphthalmic eye is a challenging task. Bigger IOLs, customized according to the size of the eye, may be a better alternative in such cases to achieve optimal visual outcomes. Thank you.